Good day. Thank you for joining me as I present the findings of our CIHR-funded multi-site international study. This study is part of a program of critical research to advance infant feeding. It is designed to support mothers living with HIV by transcending adversity through mothering. I will discuss the effects of negative psychosocial outcomes on social capital among Black mothers living with HIV. This is a north-south multi-level analysis. I would like to thank my colleagues for their contributions to the development of our research project and the data analysis from which this presentation is derived. By way of background, I will provide an overview of infant feeding guidelines for mothers living with HIV and the concept of social capital. The significance of this study is to help facilitate more equitable approaches to infant feeding choices for mothers living with HIV. Our sample are African, Caribbean, and Black mothers. However, the infant feeding guidelines apply to all mothers living with HIV. Exclusive formula feeding is standard of care in countries where formula is readily accessible and safe. Exclusive breastfeeding is standard of care for mothers living with HIV who are virally suppressed in settings where formula is not readily accessible or safe. And mixed feeding is not recommended for mothers living with HIV because it increases the likelihood of oral and esophageal lining and gut irritation in the infant that may increase the risk of vertical transmission. Evidence is emerging that mothers living with HIV in countries where formula is readily accessible and safe desire to engage in exclusive breastfeeding when they are on antiretroviral therapy and virally suppressed. In effect, in compliance with WHO guidelines for countries where formula is not readily accessible or safe. These studies are emerging in Western Europe and the United States primarily. Social capital is a collective community attribute that determines population health and well-being. Communities with high social capital are associated with better population health outcomes. Underlying mechanisms that explain associations between social capital and better health outcomes are not well understood. Historically, there were two approaches to explaining or understanding how social capital works. The first approach is through social cohesion, which is basically trust and reciprocity among community members. The second approach is sociological networks, and it is the individual members draw on networks' collective resources. However, contemporary social capital and health research goes beyond cohesion and network approaches and can be viewed through three complementary lenses, those being dimensions, settings, and levels of social capital. There are different dimensions of social capital that fall within both cohesion and network approaches to health. Those include cognitive, which are the perceptions of trust, reciprocity, norms, and values within a community. Structural dimensions, which include the quantity of relationships and membership in institutions that can bring individuals and groups together. Some examples of that would be churches or a healthcare system. The final dimension is relational, and relational social capital can be further subdivided into bonding, bridging, and linking social capital, which align with different levels of social ecology. Bonding social capital is the social resources an individual can get through close networks or groups with similar socio-demographic characteristics, for example, through familial groups. Bridging social capital are the resources that are accessed from networks or groups with different characteristics. An example here would be the types of social capital that can be built between patients and healthcare providers. And finally, linking social capital is the connections that individuals and groups have within hierarchies of power and authority. And examples here would be governmental authorities. In the context of our study, that would be the relationship between women or mothers living with HIV and the governmental authorities that develop the infant feeding guidelines. Social capital tends to take place in different settings, what we refer to as contexts. Three common settings for looking at social capital and health are within families, in the workplace, and in various neighborhood or community contexts, or in larger geographic areas. For example, in our study, we explored the effects of social capital across city or regional levels in 3 different countries. Social capital has been conceptually defined and measured at the individual and group, the aggregate or ecological levels, and the distinctive feature of social capital is that it is an ecological characteristic and external to individuals. Overall, there is a complex relationship between the dimension, setting, and level of social capital, as well as the indicators chosen to measure and represent each aspect of social capital. Now I will describe the methods we used for this study. I will only describe quantitative data that were gathered from mothers via questionnaires administered either online or by paper and pencil. It is important to note that all Nigeria data were gathered online, which is counter to what we anticipated a priori. By way of study design, the parent study was a 3-year multi-country mixed method community-based research study. It was conducted between June of 2016 and December of 2019. It was a venue-based sampling study where we worked through various venues to access the mothers living with HIV to gain their insights into the research that was being conducted. The settings for the study included Ottawa, Canada, the Miami, Florida in the United States, and Port Harcourt, Nigeria. Participants were recruited through hospitals and clinics, through community agencies, and community-based clinics. Outreach efforts in communities were guided by community advisory group members. Our sample included Black mothers living with HIV, a total of 690 of them, and they were recruited from the global north, those in Miami and Ottawa. There was 290, and 400 participants in the global south, represented by Port Harcourt, Nigeria. This study used a community-based approach and included community members at every step of the research process, from conceptualization through data collection and dissemination. The study was approved for human subjects of research ethics boards at the University of Ottawa, the University of Port Harcourt, and Florida International University. Permissions and letters of access were obtained from all sites where data were collected, and community advisory groups were established at each study site. Participants were informed of potential risks from study participation. The study was anticipated to have a lower level of risk because there were no direct interventions with the mothers. However, the survey questions and the qualitative interviews could invoke feelings of discomfort, shame, and so forth. So there were psychological risks that needed to be taken into consideration. There were limited direct benefit from study participation. Therefore, the mothers were informed of that. and they were also informed that they could withdraw at any time without adverse effect to their health care services that were received by any of the agencies where they were recruited from. Written consent was obtained prior to completing study-related activities. The variables that were included in the study were generated from scale scores from validated instruments to represent the negative psychosocial variables. Social capital variables were selected based on theoretical constructs that represent the cognitive, relational, and structural dimensions of social capital. We also collected demographic characteristics and infant feeding practices to help characterize the women and also as aspects for inclusion in the model for assessing the negative psychosocial effects on social capital. All study data were entered, cleaned, checked for double entry errors and any duplicated entries. Data were analyzed using SPSS. After quantitative data were collected at all 3 sites, they were entered into SPSS. Then they were aggregated into a single file, a single data set for analysis. The completed paper surveys were double entered in SPSS to prevent any inaccuracies. Univariate and bivariate descriptive statistics were used to characterize the overall study sample, site-specific subsamples, and to facilitate comparisons across study sites. We used hierarchical linear modeling regressions to estimate the effects of negative psychosocial outcomes on social capital. In addition to that, we used strategies of reference coding with some variables to facilitate analysis in hierarchical linear modeling, and we also used proxy variables to measure social capital constructs in the HLM. Next, I will present the findings from our data analysis. Mothers from all sites were similar in age. Time since HIV diagnosis was shorter in Nigeria than in Canada and the US. The ranges in household size, number of children, and number of children since HIV diagnosis were greater in Nigeria. Mothers prescribed antiretroviral therapy for managing HIV were high in all sites, but lowest in Miami. And most mothers in all sites were married, had completed at least secondary education, and were employed, either full or part-time. Overall, most mothers had correct knowledge of and were adherent with the infant feeding guidelines where they lived. Data on scale performance for the negative psychosocial factors are presented in this table. Each scale had good to excellent internal consistency reliability as evidenced by the Cronbach's alpha values. The t-tests to determine equivalence of means were significant at p less than 0.01, and these scale scores provide evidence of appropriateness for including the scores in our HLM regressions. Multi-level hierarchical linear regression modeling determined variations in perceived discrimination at 7%, perceived stigma at 12%, heightened vigilance at 24.7%, and perceived stress at 10%. These were explained by social capital at a p-value of less than 0.01, and independent ameliorating effects of social capital on psychosocial variables were observed. The next 3 tables are the outputs from the hierarchical linear regression modeling. With this approach, we conducted 2 models. The first model generated included the socio-demographic variables only. All of the regression coefficients are from the final step of the HLM. The interaction effects between variables were also analyzed, and this model was statistically significant for each negative psychosocial attribute. The single asterisk signifies a p-value of less than 0.05, and the double asterisk signifies p-values of less than 0.01. The second model included the addition of the social capital variables clustered by the three domains or dimensions of social capital: the cognitive, relational, and structural. These variables are presented in this table and the next table, and all regression coefficients are from the final step of the HLM. This model, with the inclusion of the social capital variables, was statistically significant for each negative psychosocial attribute, as evidenced by the change in regression coefficients and F statistics. The level of significance for the change in the F statistic was significant at the p less than 0.01 level. Trust in government guidelines was associated with decreased discrimination in mothers in the global north compared to the south. Functional social support was associated with decreased stigma at the same rate in the north and south. Trust in social networks, recommendations, and social support were associated with decreased heightened vigilance, and social support was associated with decreased perceived stress in the north compared to the south. I will now describe the implications of this study in relation to nursing practice, teaching, research, and nursing and health policy. Implications for practice. All expectant mothers and their families need to be informed of the existence of the guidelines for mothers living with HIV. Nurses who provide care to mothers living with HIV ought to be familiar with infant feeding guidelines in the jurisdiction where they practice. These nurses also ought to be aware that there are differences between infant feeding guidelines internationally. This can create concerns and considerations for and among some mothers living with HIV. These nurses also ought to be aware of the socio-cultural factors that influence adherence to infant feeding guidelines. Nurses, as trusted members of the healthcare team, ought to support mothers living with HIV to become aware of infant feeding options and to facilitate adherence to infant feeding practices that prevent vertical HIV transmission. Nurses can work with and support mothers living with HIV to achieve optimal motherhood experiences. Implications for teaching. Nurse educators can facilitate dialogue with students that increase awareness of infant feeding guidelines and differences between infant feeding guidelines globally. Nurse educators can use principles of cultural humility and cultural safety to facilitate knowledge development of the cultural differences in motherhood experiences among racial and ethnic minority mothers living with HIV. Nurse educators can teach students about the different aspects of social capital and ways in which social capital can improve population health outcomes for mothers living with HIV, their infants, families, and communities. With regards to implications for research, nurse researchers can study strategies for measuring social capital and the effects of social capital in vulnerable and marginalized populations with whom they conduct research. Nurse researchers can develop interventions that enhance social capital among vulnerable and marginalized populations to improve health outcomes. These nurse researchers can also engage in community-based research that can build community capacity and facilitate development of social capital among populations they research. Nurse researchers can also study the effects of differential infant feeding guidelines that contribute to perceptions of unjust or inequitable approaches to mothers living with HIV locally as well as globally. With regards to implications for policy, both nursing and health policy, nurses as advocates can work with mothers living with HIV to change health policies that may establish unjust or inequitable policies on infant feeding. Social capital constructs measured in this study are in support of literature that documents its efficacy to improve population health outcomes, which may be beneficial to the development of structural interventions that improve population health among mothers living with HIV, their infants, families, and communities. Developing social capital is an approach that aligns with human rights-based and decolonizing approaches that may improve health and well-being of mothers living with HIV, their infants, families, and communities. This study had several limitations. I will point out a few of those. The study subsamples may not be representative of mothers living with HIV in the cities or countries where our samples were obtained. Social capital constructs measured in this study were generated from aggregated data obtained from mothers living with HIV. As such, the mothers themselves may not perceive the benefits of their collective social capital. Future studies should include individual level measures of social capital in addition to measurement of theoretically generated variables to measure the effects of social capital among mothers living with HIV. In conclusion, nurses in HIV care are uniquely situated within contexts to support mothers living with HIV to make infant feeding choices that allow them to keep their infants safe and healthy, while achieving the benefits and rewards of motherhood. Development of interventions that build social capital among mothers living with HIV hold promise for improving health outcomes for them, their infants, families, and communities. Reconciling differences between infant feeding guidelines globally that address public health needs for protecting infant health and incorporate the perspectives, preferences, and needs of mothers living with HIV, their families, and communities will contribute to achieving the global objective of improved maternal health and reduced infant morbidity and mortality. I would like to acknowledge and thank the participants of this study who shared their life's experience. Without them sharing these experiences, we would not have been able to complete this research. This research was funded by the Canadian Institutes of Health Research, and I would like to thank the CANAC conference organizers and abstract reviewers for giving us the opportunity to present our research here. Please join me for a discussion session during the conference on May 16th from 2 to 4 p.m. Mountain Time. Thank you and have a wonderful day.